Hello, everyone. We're going to give it just a moment before we go ahead and get started for today's webinar. Thank you so much for joining us. Just let the room fill up. I hope everyone is having a great Wednesday. All right. Let's see. Okay. Well, good afternoon. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on comprehensive pain management, the old and the new, which is very timely because September is Pain Awareness Month. My name is Alsan Murtha, and I'm the Manager of Strategic Communications here at the National Hemophilia Foundation. This webinar is pre-recorded, so we will not have a Q&A today. But if you should have any questions, you will be able to email them to our speaker. Her email address is dropped in the chat for you to use. This webinar will be available to the community beginning on Friday, September 23rd. I am joined today by Dr. Kim Maurer. Thank you for taking the time to join us. I'll go ahead and turn it over to you to get started.
Thanks, Alsan. Thank you all for having me. We're going to spend about an hour talking about some older things in pain management and some newer things in pain management. And then please do, like Alsan said, feel free to email me. We'll drop that email address in the chat. My only disclaimer is I'm kind of slow sometimes. I'm getting back on emails. So I will try to be prompt with getting your answers responded to. Okay, with that, we will start. And this will take about an hour, maybe 50 minutes to an hour to kind of go through. So the first slide, of course, is my disclosure. I don't have any conflicts of interest or any disclosures for today or for this talk. All right, this slide kind of shows what magnitude chronic pain plays in our lives. And, you know, these numbers are a little old, but that makes it even more profound that the numbers are probably bigger now. But $380 billion is about what they estimate across the United States we spend yearly in chronic pain management. And this is pain management in clinics, in procedures, lost revenue from jobs in the workplace, and people calling sick or calling because they don't feel well. 112 billion of that is what is spent, not of that 380, but total overall for diabetic care. And 89.3 billion is what's spent for acute cardiac care. And the reason I put up those two numbers, the 112 billion is an 89.3 billion, separate numbers from each other and separate from the 380, is to demonstrate that 380 billion is just pain. So we are more in spending on pain than for other big conditions in our country and in our world, which is diabetic care and acute cardiac care. So pain management is a big deal. It affects suffering, quality of life, and it is a big generator for loss of ability to work and revenue sources, as well as frustration for people because they can't go to work and then they're using up vacation days for pain days and they don't have as much vacation with their families. So it's a big deal. Some concepts around chronic pain management. There are so many concepts in chronic pain management. I could talk all day, but I'm just going to give you a few takeaway items today. And a few things to talk about is nerve pain. Now, in hemophilia, we talk a lot, you hear the term nociceptive. And nociceptive is a term for the type of pain that comes from muscles, tendons, ligaments, skin tissues, joints. It means kind of an acute inflammatory pain from soft tissues or bone. There's also a big category of pain that's all neuropathic. Now, when you have joint pain, which is commonly what we see in our target joints and in patients with bleeding disorders, is nociceptive pain. But the big push lately is to realize that there is a component of nerve pain as well, because joint spaces aren't free of nerves. There are nerves in joint spaces. And as joint spaces get acute blood in them and get irritated and get inflamed, those same nerves also get inflamed by the inflammatory process or by blood or mechanical rubbing or bone on bone rubbing and smashing those nerves in between the bone on bone. So I like to give a little background on neuropathic pain because we spend so much time on nociceptive pain that I think it's nice for you to have a little bit of a background on the nerve component of pain. Now, the nerve component of pain is interesting to know because mainly it's important to know that nerve and nociceptive pain, so neuropathic and nociceptive pain, is just physiology gone awry. It's like our physiological system saying, whoa, we are out of balance. That teeter-totter is not balanced on both ends. And it's important to know that most of the time, if a nerve gets squished or smushed, for lack of a better word, between bones or by a surgeon's retractor or by an object, if you get a crush injury and something falls on you, it doesn't lead to ongoing pain. Most of the time, the nerve kind of reheals itself or calms down its firing patterns, and everything returns to normal. That's 90% of cases. And it's also important to know that when a nerve is irritated or smushed in a joint or irritated by blood, that does not always correlate well with severity of pain. So knowing that how a nerve looks under a microscope or how it's firing in the body does not have to correlate with the pain. A nerve can be really, really funky looking and firing funny, and you can have no pain. Or a nerve can be relatively normal in firing and appearance under a microscope and cause a lot of pain. So that's important to know too. And there is no test to tell how bad or good or severe or light pain is. And that's also important. So we can get electromyography studies, we can get these nerve conduction velocity studies, but no test really tells us how a nerve functions. We have no way to look at that. We can see if a nerve is firing and we can see a picture of a nerve, but we can't really put those two together and get a good test to say this nerve is functioning at 70% or 80% or it's irritated today. And the other important thing about nerves is, the entire nervous system can be involved. So when one nerve is aggravated, in say my pinky finger here, it doesn't just mean that my pinky finger hurt. That can set up a whole cascade with my entire nervous system. And when we talk about the central nervous system, we're talking about the nerves in the brain and spinal cord, but it can be the peripheral nervous system too, which refers to all of our nerves outside of our central nervous system, so outside of the spinal cord or the brain area. And then, of course, as many people know, and any of us who've had chronic or acute pain know, pain can really change everything in your life. It is not just the pain, right? It's really more about the mood it does to you, the ability to work, the ability to play, the ability to exercise, what you crave to eat because you're hurting or cranky or fussy or distracted by your pain. So it really affects the whole being. Now, this you've seen a lot if you've heard me speak, and I apologize if I'm boring people with another repeat slide, but it's really important to understand the concept of the definition of pain. And this definition, this is an older definition. We've changed it a little bit to add some components of neuropathic pain in it. But the important thing and the takeaway with whatever definition or version of the definition you're reading is that pain is sensory and emotional. And that's really important to remember, that this is an emotional experience. And when we tell people pain is emotional, we are not trying to say that it's in your brain and you're wimpy or you're weak or you're faking it or you're just looking for an excuse or you're crazy. That's not what the emotional component of the definition means. The emotional component of the definition means that pain processing affects the frontal lobe and your amygdala. And in affecting those areas, in those nerves in those areas, people do feel more distracted, emotional, angry, upset, calm, irritated. All of those emotions come into play because pain is an emotional experience, meaning that it's going to affect our emotions. That's what it's supposed to do. And it affects everyone's emotions differently. That is a lot controlled by the amygdala. And when we unlock the key to how the amygdala is controlled, we'll let everyone know because we don't know that yet. And what is neuropathic pain at a physiological level? I explained to you kind of how it can look and how it can be, but what is it at the physiological level? And a long time ago, in 1994, we gave it this definition that it is pain that's caused by a lesion or dysfunction. And when we use the word lesion in pain medicine, it sounds like a cut or a sever or a tear, but lesion, or it doesn't mean like a tumor lesion like in cancer, but lesion just means an alteration or an abnormality in the primary nervous system. And primary nervous system means your central nervous system. That's kind of like the godfather of the nervous system. And then the peripheral nervous system is secondary, or dysfunction, meaning that the nerve is firing funny. And it was a very simple definition that you had to have pain that started in the central nervous system because something wasn't functioning well, or caused by something not functioning well. And then we said that's not specific enough. And so then we added to the definition that it also can arrive out of consequences of diseases that affect the somatosensory system. The somatosensory system is part of the central nervous system, but also involves your tissues, your muscles, your joints, like we talked about with hemophilia and von Willebrand's and bleeding disorders, or osteoarthritis or rheumatoid arthritis, things that could affect your joints. So we said, in addition to be a primary lesion, neuropathic pain can also be pain that comes from diseases that affect our central nervous system, our somatosensory system. So think of arthritis, think of multiple sclerosis, think of Raynaud's, think of Parkinson's, all these neuropathic kind of conditions. And then we decided in 2008, and we proposed this idea that we wanted to grade nervous pain, grade neuropathic pain to be definite, probable, or possible. And the reason we wanted to grade it, and that actually really hasn't happened yet, although you'll see grading systems in the definition, is because, just like I told you, there is no test to grade it. I have no way to say that when my foot is hurting today because I stepped on a needle and I damaged a nerve in my toe, that I have definite neuropathic pain. Or do I have probable neuropathic pain? Or do I have possible neuropathic pain? So as I told you, there's no test to look at that and say, oh, Kim has a nerve firing funny, it is definite neuropathic pain. Because, like I told you, even if we do an EMG and a nerve conduction velocity and see that my nerve looks funny and it's firing funny, that still doesn't mean that I will definitely have pain, because the testing score and the testing picture don't always match up to the pain we experience. And part of that is because pain is emotional, and everyone's emotional sensory areas process those firing patterns differently. So some people can step on a pin, get probable nerve damage because you see the nerve not firing, and feel happy about it. I mean, that would be abnormal, but that could happen. That wouldn't be very likely, but some brains could process it that way. So our old definition, pain initiated or caused by a primary lesion or dysfunction in the nervous system, IG, these are some examples: painful diabetic neuropathy, postherpetic neuralgia, that comes after shingles, central pain. And the new definition, pain arising as a direct consequence of a lesion of the somatosensory system. We've basically taken the old and new and kind of put these together. And by putting these definitions together, we are now saying that we can have nociceptive pain coming from the somatosensory system and neuropathic pain coming from things like diabetic neuropathy, central pain, stroke pain, and all together, this is neuropathic pain. And that is why neuropathic pain can be in joints and somatosensory systems and somatosensory organs and somatosensory structures. So the point to all of this and all of this babbling I'm doing up here is to tell you that neuropathic pain is really a broadened definition now, and joint pain isn't as simple as just nociceptive pain. It's also neuropathic. Now, when we look at the human body, this is just a little blue replica of someone with pain, we think, gosh, wouldn't it be so nice if pain was in that pinky finger on the left hand and there was one thing in the left hand not working and we could just fix it and it would be gone. And it's really not that simple, because 3/4 of all people, not just in the United States, but across the entire world who present with pain have multiple pain sites. And so we really have to look at pain as the whole entire human being. And the reason that happens, that you get multiple pain sites, is multiple reasons. Because even though the pinky finger may be what's imaged, it starts this inflammatory cascades of neurons and neurotransmitters and inflammatory mediators. And over time, then the wrist kind of hurts and the arm kind of hurts. And then I don't use that hand as much, so my other hand gets overused. Or then I'm cranky, so I'm like holding my arm and sitting at my desk, and then my shoulder and neck start to get tight because I'm sitting funny. And it kind of affects really the whole human being. And we see this a lot in conditions like fibromyalgia. These are kind of like the really big conditions that show us all over pain, like fibromyalgia, irritable bowel, chronic pain syndrome, chronic migraine. I mean, think about it. When someone has a migraine, really bad migraine, they're like, gosh, I got to lay in bed with the lights out and my whole body feels like I have the flu. And that's kind of this overwhelming inflammatory immune response that happens in chronic pain. So when you think of pain, and especially chronic pain, it's really just a single site or a single symptom. And so we've tried to get away from just using the term pain generator or like looking for one thing. And we kind of say, let's just not target a certain symptom, although we can target if there's one symptom that's bothering a patient most predominantly. But let's target the syndrome and kind of say, gosh, how's it affecting your eating? How's it affecting your sleeping? Are you yelling at your husband or wife? Are you crankier with your kids? Are you more upset by the weather? Like, can you not drive to work? We look at it as the whole being. And that's really kind of what started as we got this research about chronic pain. These whole new terms of integrative, alternative, comprehensive pain. And we've really learned that it's just such a comprehensive problem. You know, acute pain may truly be just one little thing, but acute pain can rapidly turn into chronic in 3 to 6 weeks. And then chronic becomes really a multitude of sites and symptoms. Now, this slide is purposely made to look really messy. If you talk to someone who makes slides for a living, they would say, never present a slide like this, probably, right? Too messy. But I kind of did this on purpose because I wanted you to see how messy chronic pain really is. So the reason we haven't solved chronic pain, or one of the reasons we haven't solved chronic pain, is it's like immensely complicated. I mean, it's like fixing the war in Ukraine and fixing the recession and fixing politics in the United States, right? Like it's got all these layers and shareholders. And when I mean stakeholders and shareholders, I don't mean politicians and leaders of the world. I mean neurotransmitters and structures in the body. And I'm kind of going to go over a grab bag of the ones in orange, just so you have a little understanding of what's going on beneath our skin, beneath the surface. And there's all of these things. So central sensitization is a phenomenon that happens between the brain and spinal cord. And you see on the picture that are things that involve calcium modulators, NMDA receptors, and others. I put others to mean like levodopa, CB2, that's your cannabinoid, and THC for your marijuana or your endocannabinoid products. We have central alpha agonists like clonidine. We have things like ketamine and dextromethorphan and cough syrup and methadone. And then you have all these medicines that affect the calcium channels on nerves in our body and in different sensory pathways like pregabalin, oxcarbazepine, lamotrigine, all of these different meds that kind of try to tone down and put out the fire. And I always think of the brain and the spinal cord as like a system that really doesn't have a fire going, but they think there's a 5-alarm fire code going on. Or I think of them as a system that really wants that fine-tuned radio station to play music really clear, but all the brain and spinal cord can do when you have chronic pain is play a fuzzy radio station that you keep turning the dial and you can't get the station clear because they're just on fire. They're just not settled. And then the NE and 5-HT at the top stands for norepinephrine and serotonin. And these are transmitters and pathways we think of in depression and anxiety, but they play a big role in pain. And these are things in medicines that help these areas like your SSRIs, your Wellbutrins, your Prozacs, your Celexas, your Tramadols, your pain medicines that are opioids, the Vicodins, the hydrocodones, your TCAs, your amitriptylines, your desipramines, your imipramines. And then also from the brain to the spinal cord, you have all your opioid receptors. That's where they really lie in the body. And that's your tramadol, buprenorphine, Suboxone, methadone, morphine. You know all these names. And that pathway from the brain to the spinal cord that plays a big role in pain called descending inhibition. And there's a lot of great talks on descending inhibition. And then we have this term called peripheral sensitization, which is from the spinal cord out to the peripheral nerves. And things that affect that are kind of more of these sodium channel blockers, calcium channel blockers, carbamazepine, oxcarbazepine, TCAs, topiramate, lamotrigine, mixilotine, lidocaines. And then the peripheral nervous system, where we see neurotransmitters start their firing pattern, where we have what we call mechano and chemoreceptors, are things like our non-steroidals, like our ibuprofens, meloxicams, Aleve, Motrin, our vanilloids, our capsaicin, Qutenza, Salonpas, TRPV1 receptors, substance P, all these things you hear about in the periphery. And if you take all of that together, you get this kind of messy chicken soup where each person's playing their role. And it gets very, very confusing because you give one med, which affects another level, and that level affects another level, and that activity affects another level. And it's why chronic pain is just so complicated to treat, because then sometimes you get so many meds going, you're having side effects from the meds, and then patients are like, is my side effects from my meds worse than just having the pain itself? It's very big kitchen soup, and we're spending lots and lots and lots of dollars trying to sort it all out and simplify it, but it's not simple. The more we study chronic pain, the more we realize it's a really complex process, probably as complex as the brain itself. And this screen kind of talks to you about this sensory sensitivity. That's another word for that is central sensitization or hyperalgesia. And what it means is like everything in our body, anger, frustration, blood sugars, red blood cell counts, anxiety. We have a physiological process, right? The body lives in something called homeostasis, and everyone's homeostasis is a different level where you're fight or flight, running away as a caveman from the lion, or you're calm, sleeping at night, watching a movie, falling asleep on the sofa, where those systems, that sympathetic and parasympathetic, are in balance. And everyone has a volume control on that balance. And when we're really stressed and we're running late, that sympathetic system takes in and we get a little sweaty and we feel our heart palpitating and we just feel frustrated and angry and our thoughts are confused. And when we're really calm and we don't have a lot to do and our house is picked up and the kids are in bed and we're watching the news, we kind of are like in a peaceful state and we're calm. That parasympathetic tone, that calming tone takes precedence. And our brain and spinal cord are supposed to have a balance too, and they have a volume control. And it's somewhere in that volume control, that radio station, for where they process pain. And a lot of it we now know from these wide scale, they're called GWS, genetic wide scale studies, are determined by the genes that we're born with. And we modify these genes with these neural humoral factors and our neuroplasticity. So you're born with the genes you get, and then your nerve system is modulated by the environment, by the experiences you have, by your learning to be more flexible to control those volumes or be more rigid to not control them. And you get your own awareness of how you can turn up and turn down your volume. Some of it we can control and some of it we can't. But we know that the higher this volume control setting and the more that people can ramp up and ramp down and be anxious and be sad and be less homeostatic will kind of be the more pain we'll experience. But it's not that clear cut. So if everyone just felt balanced all the time to say we have no pain is not true, because it's not that simple. But we do know that that volume control in the spinal cord and our ability to be fired up or calmed down is somewhat independent of actually the stimulus we're getting in. Case example, I'm holding my coffee, and let's say I all of a sudden it's not hot anymore, but if it was hot and I spilled it on my hand, that should produce a pain response. My ability to monitor that pain response is kind of actually irrespective of how hot or cold that coffee is. And we're learning that it is not so much the stimulus that happens to us, but it's how our body processes the stimulus. So two people being run over by a semi-truck, one may be like, I cannot breathe. Well, you probably wouldn't if you're run over by a semi-truck, but I'm unconscious, I'm miserable. And some people might be, okay, I hurt a little bit, even though they have the same stimulus. And a lot of that is our genetics and the way our neurons have a term called plasticity, which is their ability to modulate pain signaling. And at the very dark end of that scale, the red, is this diffuse hyperalgesia and allodynia. So these are the pain states where the body is just going crazy. And fibromyalgia is one of those. And it's not a person's fault if they have fibromyalgia. It is just how their neuroplasticity can respond to the world around them. Now, opioids over time have kind of worsened that volume control. Opioids at the wrong dose in the patient who doesn't respond to them and in the wrong conditions can turn up that volume. It's not to say opioids are bad. They are definitely not bad. They are some of the best ways to control pain we have. But it can be a way to monitor that system is by monitoring how opioids are doing for us. And this slide is just a simple slide, not to make this an opioid talk, because I know we all get tired of hearing the opioid talks, including myself. I mean, give a lot of these opioid talks, is that we used to really use long-acting opiates because we thought, okay, let's give Kim MS Contin and make her as calm as we can all day with a steady state med, and then limit when she takes Vicodin. And she only takes Vicodin when she's just really stressed out and having a bad day. And now we kind of got away from that because we realized when we keep that long-acting opiate in the system all the time, then our body really says, ooh, I'm going to ramp up more because I've got opiates around all the time. So now we just kind of do short-acting and we try to limit them. We try to keep people to about 90 tablets a month if we can, 3 times a day. You know, we're trying not to do the 4 times a day, 5 times a day, 6 times a day, 120 tablets, 180 tablets a month doses anymore. And we're moving towards buprenorphine. And you guys have all heard of buprenorphine as Subutex, Suboxone. There's all kinds of different names for it. But we're moving to that, Butrans, because it's not just for what we used to call MAT, medication-assisted treatment, for people who are worried about use disorder or dependency, but we're using it for pain in general because buprenorphine is like the cousin to an opiate. It's an opioid, but it's the cousin. It's kind of like a little less potent. It's not in the family all the time, causing problems in the system. It kind of visits, right? It visits the neurosystem because it's a partial agonist and a partial antagonist. And by giving us that pain control with the agonistic portion, it's great. But by not being there so strong and like always knocking at the door, it's not irritating, right? It's not that your cousin is irritating, but it's kind of letting the system do its own thing without too much input. And that's what we want opiates to be. We want them to be there, but we want them to kind of be a slight little light layer on the cake, not a big, heavy frosting. That's what we're doing with opiates. So when your doctors are cutting you down, don't take it, hopefully you don't take it personally as like you're a bad patient or they're mad at you or it's all about their license. And there may be some of those doctors, hopefully not, but it's usually just about that they're trying to do the right thing and put a little bit on, but not too much so that they make you worse. And a really important concept in opioids is rotating them. I always like to tell people, try to rotate your opioids. Even if you're doing okay, rotate them around. Rotating them around says the body is very good. The body says, hey, look, Kim rotated me. What you got coming in now? What's this tramadol? I had Vicodin. What's this new thing? And I kind of like sees it. It's like, oh, it's a little different. It's kind of like when you wear the same pair of pants, you get tired of them. And then someday you find a pair of pants that you haven't worn in a long time. You're like, I feel a little fresh today. Got something new. Kind of the same idea. And this slide, I'm not going to go through the whole slide, but you'll get copies of slides, is to tell you kind of how to do it if you're going to do it, or kind of how most people do an opioid rotation. It can be a slow process or a fast process, but I rotate my patients all the time. I'm like, hey, let's go to Vicodin for a few months, back to oxycodone, back to tramadol, back to Nucynta, back to Vicodin, back to oxycodone, switching it up. Just like we wouldn't want to eat the same lunch every single day, we don't want our bodies seeing the same opiate every single day. And really, when you do rotate them, you do see a better effect. And the time to rotate them is when you're having those adverse effects, when you're like, gosh, my opiates are just making me too sleepy. When you're seeing a diminished effect, when you're seeing that they're not working as well, when you're saying, I just can't afford this prescription. My economics and my financial situation are playing into it. This medicine is just not covered by my insurance anymore. Or when you see that your pain's changing and you're like, gosh, my pain is changing a little bit. Maybe I should rotate things around and see if I can get something to work a little better for myself. And we have all these tools. And I know the tools can be frustrating that every time you go to a provider's office, you got to fill out another questionnaire. But we keep questionnaires for several reasons. And I always want patients to know the reasons so you don't feel like you're being personally kind of picked on to do another tool or a questionnaire. And we do it for a lot of reasons, but one reason we do them is to collect data. You know, over time in human studies and watching patient after patient and provider after provider, It's how we learn about what providers do good and bad and what works for patients good and bad. And the other reason we do it is truly litigation legal, not litigation like doctor suing patient, patient suing doctor, but because the Federal Drug Administration and the Drug Enforcement Agency of the United States does realize that these meds can cause dependence, and they have taken lives accidentally because people have accidentally taken too much or sometimes purposely taken too much, that there's a really tight regulation around them. And so one of the things that the government and the state medical boards like us to do is what's called an opioid risk tool. There's many of these. One's called Dyer, one is called SOAP, like you wash your body with, SOAP R. But these tools really are helpful to really kind of say, all right, Kim has the potential, just has the potential from this tool that if she gets really, really stressed, she may reach for another Vicodin because her brain is kind of wired to like feel like she needs something to help her out. Or Kim is really low risk of ever getting into problems on these meds. And it isn't something we use to definitely say prescribe or don't prescribe, but it tells us a little bit about what your genetics and your cravings may do in times of stress, in good times, in bad times, when you're hurting, when you're not hurting, when you're sad. And that is not anything anyone should ever feel bad about what their answer is on the score, because a lot of this is hardwired into us genetically. It's nothing we did to be good, bad, middle, whatever you want to call these scores. It's just kind of how you're wired. And a lot of that is our genetics, which, you know, they always say you choose your friends, but you can't choose your family. We all get the genetics we all get. And these are ways to start medications. If your provider were to be starting you on pain medicines, these are some of the ways you would start them, the very beginning doses. And it's very important the first time you're starting opiates, if you are taking an opiate, to always be on the lowest dose possible. Now, maybe the lowest dose possible isn't going to be enough for you, but the lowest dose possible will keep you the safest, and it'll keep you from getting tolerant more quickly. And naloxone is the reversal medication we give a lot. This is really important. And this is the medication that they give out now in pens or atomizers or injectables at the pharmacy. And pharmacists can now give these out when you pick up your prescription, even if your provider hasn't ordered it. And the reason why is we know these can save lives. And, you know, the other day I was with a partner on the street and, you know, he had one with him because there was a guy who was accidentally overdosing, you know, in the streets of Portland. But these can really save lives. So we do like to have people have naloxone in their homes because it's not going to hurt someone if you give it at the wrong time. But if someone is not breathing well or too sedated, or a friend, or, you know, kids are at a party, these are really helpful to have around. And they have them now in the airplane emergency kits. They'll have them in gymnasiums. They have them at public football, baseball, soccer stadiums and kits. They have them in shopping malls. These are kind of found everywhere because it can really save a life and bring back someone and help them breathe again. Because the way that opioids can hurt people is by stopping breathing. And so moving on from opiates onto all this other stuff we're doing. Why are we doing all this other stuff? Well, we call this non-allopathic treatment of pain, and we're actually getting away from calling it non-allopathic because it is allopathic, or it's non-allopathic. Allopathic and non-allopathic are all rolled together to mean we all work together. It doesn't have to be a traditional old-fashioned way of doing pain run by MDs or DOs or nurse practitioners or advanced practice providers. Everyone has a hand and has a role in curing and helping and trying to cure, because remember, we don't have a cure yet, chronic pain. So we do things like chiropractic and acupuncture, massage and pain psychology and Reiki and CBT and yoga and mindfulness and Rolfing. And we do all these not because we have a lot of tons and tons of efficacy studies to say these are the best things ever, but we do them because we know that they have very, very good safety studies and they don't hurt. And we're starting to find they probably do help. We're starting to get early studies that say, all right, Kim has the genetics that she has, that she's going to feel pain how she has. But these things can tone down that fuzzy radio station, calm her and relax her to make her body process pain signals less fast. And if a nerve goes from being Speedy Gonzalez and firing like this to firing like this, guess what? When a nerve fires like this, it carries less pain signals. The C fibers in A delta carry less pain signals and you feel less pain. So we are doing all these things not because we know exactly what they are doing, but because we know that they aren't hurting us and we think they're starting to help a lot. These are all things that insurance companies are coming on board to cover now, which is really, really great to see. Plus, there's other benefits, not just health, but there is the benefit of relaxation. There is the benefit of calming, helping with anxiety, helping with those stress levels. And this is the buprenorphine I talked about. You know, it came out in 2001 in the USA, and we don't really call it neurotherapy anymore. It is less controlled than your opioids. It's a Schedule 3 instead of Schedule 2. And remember, the bigger your number on your schedules, the less controlled or less dangerous it is for you. And it is only a partial mu agonist. Remember, mu, mu, is the type of receptor in our body that opioid medications bind to. And buprenorphine really holds on to that mu. So that's why you don't have to take it as often or as big of a dose, because it really has a power punch when it hits. And you don't have to get it with naloxone. Naloxone is the reversible thing that can save a life. And so we put it in the medications when we're worried that someone might take too much, because the naloxone kicks in and it can save your life. But some people don't need to have the naloxone because they're on lower dose, so they're not worried about accidentally taking too much. And it comes sublingual now, dissolvable. They have all these fancy forms to give buprenorphine. And we do just use it for pain. It's not all for someone with a use disorder who wants to wean or detoxify off their opioids. And low-dose naltrexone, it gets confused a lot with naloxone. Remember, naloxone completely reverses an opioid medication. It's a pure antagonist. It blocks the receptor, pushes things off, the mu. Naltrexone is a pure antagonist too, but it's a much weaker one. It's like Baby Bear, not Papa Bear. And Baby Bear, as came out in 1984, it was actually out way before buprenorphine. Naloxone was out before both of them. And it just blocks the receptor. And we used to use it for use disorder or alcohol use disorder. And we gave really high doses because it doesn't have side effects. You can give a lot of it. But now we kind of use it for these central sensitization syndromes. And really, we're moving it into all types of pain. But we use it for the fibromyalgias and the irritable bowel and the chronic migraine and these things that are just always the body is stressed and hurting. And we use it because remember what we talked about, how we have these abnormal inflammatory immune responses. And the body's all like this, and the radio station is all loud, and we can't get that fuzzy radio station to a really clear station on either side. Low-dose naltrexone, kind of in low doses, you have to do less, works better. It's a paradoxical effect. You think high would work better, but it doesn't. Low doses kind of increases our natural feel good, our endorphins and our catalysts, so we calm. That first sip of coffee in the morning, the first bite of chocolate, the really good closing on a good movie, it increases those feel-good hormones. And when we increase our feel-good hormones, watching our favorite movie, we kind of normalize our immune response. And we're trying to calm down the radio station, calm down the immune system. And naltrexone is a really good calming medication. It also balances your mu-opioid receptors and your delta receptors. And when you balance those two sets of receptors in the body, you also calm down the immune system. And so by blocking a little bit of the mu, you let the delta kind of free float around and you kind of balance them, because usually we live with a lot more mu than we do delta. And it's that balancing effect that really can start to tone down the radio stations and to tone down the fuzzy station in the brain and spinal cord to help the overall pain. And we also know that in the spinal cord lives our glial cells. These are big macrophage, however you want to say it, macrophage, most people say macrophage, white blood cells that activate the immune response. And we don't want to activate the immune response in pain. So there's some thought, and I put question marks here because it's not really proven in humans, it's proven in rats and dogs. So this probably happens in us, that we can prevent these cells from being activated by using this low-dose naltrexone. A little bit more about it. That's the high dose, the 52-300. We use doses of 4.5, 2.5. Those are what we talk about low dose. And it's really balancing that teeter-totter. Low dose naltrexone takes that mu that's like always heavy and delta up here and tries to get them back in balance and says, let's have a little delta and a little mu, a little peanut butter, a little jelly on our sandwich. Not all peanut butter, not all jelly. Balance, homeostasis, the human body. And then marijuana. Many of you probably see the slide. I probably need to change the slide around, but marijuana is really starting to play its role. And it's not the marijuana so much, but it's components of the plant. Remember, marijuana is a plant. It's a plant grown in nature that has different components and alkaloid and substances in it. And it has components of a THC, a tetrahydrocannabinol or hydrocannabinoid, and a CBD. And different components of these natural products in this plant can be extracted to help with pain. And the literature is still very new. It's still not super good literature. But what we're finding is that when you extract more of the CBD, the cannabinoid component of the alkaloids of this plant, you can really help with that immune response, kind of the same way naltrexone does. I predict in the future, chronic pain will be giving people naltrexone and CBD, probably a little bit different than now we give gabapentin and Vicodin. We'll be giving naltrexone and CBD. But the idea is to extract the CBD from the marijuana plant and help with this inflammatory response. And there's a lot of clinical trials going on to look at this. There's 4 products over here on the screen you see that are out that are CBD products for children and for seizures, for epilepsy in children. And this is what hemp is. Hemp is a plant that's kind of manufactured to be more CBD to get the good part out of the marijuana. The CBD is the part that seems to be more medicinal. And it does bind naturally in our body. So we have these endocannabinoids. So these are these molecules that float around. They're called our endogenous cannabinoids, or the endocannabinoids, standing for endogenous cannabinoids. And they bind to CB1 and CB2 receptors. And what's interesting is the CBD on the CB2 receptors. CB2 receptors are located on our microglia, on those glial cells and on immune cells. And we don't want them to get activated because we don't want to activate the immune response. So we can kind of block or bind these CB2 receptors to keep that overall immune inflammation down with CBD. So we're doing a lot of studying of these CB2 receptors on the microglial and the glial cells and immune cells to see if we can calm inflammation. And I think this is a big what if, so don't take this for total truism, that, over time, we probably will have something for pain that's tablet or IV form or liquid. That'll be prescription. That'll be a CB2 agonist for inflammation and chronic pain. And I think it's going to be great in the bleeding community because a lot of the pain that people have is an arthritic musculoskeletal joint pain, and it's going to be really good for chronic arthritis pain. I mean, it's going to help everyone because we all get some arthritis as we get older, but especially when you have target joints and joints that have been damaged by recurrent or repeated bleeding. And IV lidocaine is something that's kind of still floating out there. We do it in the hospitals. We don't really do it in the clinics. But it is a way for people to calm the nervous system by an IV lidocaine, basically like dentists used to numb your mouth. And we do it a lot for fibromyalgia and abdominal pain in the hospital. We don't really do it outpatient because we really don't know the benefit in chronic pain. But in acute pain, it seems to work really well for those two conditions, for centralized pain components like migraine. So you're going to see more coming out on IV lidocaine. As you can tell, this is the new part of the talk. We did the old part of the talk, which was opioids. And ketamine, ketamine is getting more and more popular. You will see the federal government, though, really act differently around ketamine. I think they got scared after the opiate epidemic. And because ketamine is a controlled substance and it can be abused, it's called Special K out on the streets. It's one of its name. The government is really being careful with ketamine not to let what happened with the opioids happen with ketamine. So they're really keeping a tight watch on it. But it blocks the glutamate NMDA receptors in the spinal cord and brain. And it seems to really help with refractory neuropathic pain and people who are tolerant to opioid medication. So different than naltrexone and the CBDs, which kind of work for inflammation, ketamine works when someone is just like got this pain that nothing touches. The naltrexone doesn't help, blocking inflammation doesn't help. Their opiates aren't working anymore. They're kind of immune to them. So ketamine is kind of our big gun to come in and kind of reset the body. It's like turning off the computer and turning it back on and hoping it works when you turn it back on. There's different ways to get this NMDA receptor response. You can do it with amantadine, which is like what's in the flu vaccine or what we use sometimes for the flu. Dextromethorphan, which is a cough syrup. Memantine, which I use a lot in the hemophilia clinic here in Oregon, which is a anti-neuropathic medicine. And then, of course, ketamine. NMDA is one of those central processing molecules and neurotransmitters that we have along the brain and spinal cord. And we did it. Look at that. We probably got our 50 minutes in. There is my speaker contact information. I think we're also going to pop in the chat for you. And hopefully that was a little whirlwind tour through pain. And I'm happy for any emails, always happy to talk. If anything I said doesn't make sense or seems wrong or I misworded something, please just let me know. And thank you for having me. And I think Allison has a few closing remarks.
I do. Yes. Thank you so much for taking the time to join us this afternoon. We always appreciate your time and expertise. And I'd like to thank, thank you. I'd like to thank each one of our viewers for joining us as well. Just remember that this pre-recorded webinar will be available on Friday, September 23rd at hemophilia.org under the events tab with all of our archived webinars. Also available in the events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you again for joining us this afternoon and have a wonderful week.